Well, good morning, everybody. It's really great to be here, and I'm going to take us sort of upstream and think about how we can prevent people either getting mental illness or living better with it. And I'd like to acknowledge that we're meeting on the lands of the Gadigal people, the Eora Nation, and pay respects to their elders past, present and emerging. And I also like to always admire the resilience of First Nations people through the processes of colonisation. I'd also like to acknowledge my research team. All this research is being done in partnership with my team at Adelaide University, where we live under the name of the Stretton Institute, which is Hugh Stretton's, named after Hugh Stretton, if people remember him as one of Australia's great intellectuals. Just to give you an overview of what I'm going to talk about, I'm going to first of all look at the growing health and economic inequalities that are affecting Australia, then look at how everyday living conditions affect mental health, then look at the sort of structural, social and commercial determinants of mental health. And you'll see at the bottom, I am going to end, I noticed two of the opening addresses talked about hope, and I will try and be more hopeful in the last bit of my talk, otherwise it could be a bit depressing. So if we think about health equity, it's not the same as equal, it's about being fair. So if we had everybody with fair health, then we would have health equity. It doesn't mean we'd all be the same, but that there would be fairness. And what I'm going to just look briefly at the social epidemiology of health inequity, according to socio-economic inequity, Aboriginal Torres Strait Islander, then think about gender, and then think about the impact that mental illness can have on other health aspects. I guess the headline message is that in Australia, health inequities are growing. They're not getting smaller. If we compare ourselves with around 1990, when if you compared the top with the bottom group, there was about 1.5 difference. We've now moved out in terms of life expectancy. We've moved out to 2 times. So we are getting less equitable as a nation. And you can just see here, if we looked at deaths in COVID, if you were in the lowest CFO, if you lived in an area that was the lowest socioeconomic, then your share of the deaths was 33%. If you lived in the highest, it was under 10%. So we saw that inequities playing out. And what was interesting is we saw that around the world. That wasn't just Australia. And then if we ask people who, these are data from the ABS, if we ask people about their own health status, you can see that there's a real gradient. So it's not just that there's these disadvantaged people at the bottom and then the rest of us. There's actually a gradient across society. So if you're in the middle in quintile 3, your health is better than the people at the bottom, but not as good as people at the top. And I think very often we forget that when we think about health equity. We just want to talk about the disadvantaged. And if we look at people who are unemployed, you can see that long-term unemployment is really bad for your health, where about 19% of people are reporting psychological distress, whereas people who have enough hours, who are working as much as they want, it's about 3%. So again, very big inequities. In terms of Aboriginal and Torres Strait Islander people, we have a fantastic closing the gap strategy, and I think very much we haven't managed to close that gap, and I think it is a human rights issue, much the same as Brian Burton described for mental illness. Life expectancy gap is narrowing slightly, but it's still there. If you're an Aboriginal man, you're going to die 11 years before non-Aboriginal people in the country. And you can't see this very well, sorry about that, but the top line is suicide deaths by Aboriginal status. The green line is Aboriginal people. The other line is other Australians. So you can see we certainly haven't closed that gap. That gap is still there. And then if we look at people who go to hospital because of mental illness, and the blue, dark blue is Indigenous, the yellow is non-Indigenous. Once again, you can see that at most ages, Indigenous people are much more likely to be hospitalised for their mental illness. And you'll see that's particularly the case in those middle years, people from 25 to 54. That is a massive difference. And then if we look specifically among Aboriginal people, if they were part of the stolen generation, then they're much more likely to report high or very high psychological distress. And it doesn't take much imagination to realise why that would be the case, but there it is. And of course, in terms of comorbidity, it's already been pointed out that people who are experiencing psychosis are much more likely to have heart conditions, diabetes, epilepsy, severe headaches, and that worldwide it's been calculated that people with mental illness have 2.2 times the rate of physical illness. So that, as you can see, there's something going on there. It could be to do with susceptibility, but it's also very likely to do with access to services. And in terms of gender, men and women have roughly the same reports of mental disorder at some point in their life. Women experience anxiety much more than men, and overall, women tend to experience more mental illness during their lives, but in terms of suicide, much higher rates than men. And I think most of you here would be aware of that. And if we again look at suicide rates by that measure of socioeconomic area in which people live, again, there's that gradient. You can see how it goes down. So if you live in a more advantaged area, you're less likely to commit suicide. And then in terms of psychological distress by people with different genders and sexualities, you can see that once again, there's an elevated rate for people compared with the general Australian population. So that's just giving you a picture of what we know about the rates and how unequal they are. I spent 3 years working with the Commission on the Social Determinants of Health that was established by the World Health Organization. And there we looked at two forms of inequity. We looked at everyday living conditions, and I'll talk about those: housing, income and wealth, education, unemployment, housing and health services. But then we also looked at what we called the sort of structural factors, and I'll talk about those after I've talked about the everyday living conditions. With my research group, we've just written a report for the National Mental Health Commission on priority populations and mental health and suicide prevention. And I've just got a quote here from one of the people we spoke to as part of that study. And they really talked about how important that human rights principle is. And I think we've already heard a lot about that. And just pointing out that those everyday living conditions like housing, education, health and employment are really vital. And if those aren't working in your life, you're going to be much more susceptible to the experience of mental illness. And we do know that social determinants of health have probably contribute about half to our health and our risks of dying at an earlier age. Physical and environmental factors are also important, biology and genetics. Healthcare makes a very important contribution, but those combined social and economic determinants are responsible for something like half the burden. So the next thing I want to think about is economic inequities. And of course, these underpin the health inequities that we've been talking about. And usually when you see economic inequities growing historically, that's followed by a growth in health inequities. So if we look here at global income and wealth, this is incomes on your left, wealth on the right, you'll see that 10% of the population worldwide get 50% of the income. The people in the bottom half only get 8% of the income. If we look at wealth, then 76% of the wealth sits with 10% of the population, and the bottom 50% has 2%. So it doesn't take much imagination to see how unequal that is and how so unfair it is. This is some figures produced by the Australia Institute. And here they were looking at, in terms of the share in the growth of what they called economic growth, how much goes to the top 10% and how much to the bottom 90%. So if you look at the period on your left, 1950s to 1960s, the bottom 90% were getting 96% of the growth at that time in terms of real economic growth. But look forward to 2009 to 2019, and you'll see that it's totally reversed. And 93% of the gain is going to the top 10%. So that's a dramatic change in Australia, really dramatic. And it's not just a figure, that will have very real consequences on people's lives. And I think we're sort of seeing that in the breakdown of when we look at cost of living and housing crises and so on. And the World Economic Forum, which isn't known for its progressive positions really, has said that the average billionaire has gained roughly 1.7 million for every dollar of new wealth earned by a person in the bottom 90%. And then they go on to say, and this is a quote from the World Economic Forum, yes, really, you may want to read that again. And it points out that this kind of inequities is about the accumulation of wealth and power in a few hands. And it is corrupted and polarized our politics and media, and it's also eroding our democracy. And I think it's also eroding our sense of fairness and our sense of kind of solidarity, because the extremes in wealth are becoming so great. Now, I'm sure most people in this room aren't surprised by the fact that being poor threatens your mental health. If you're poor, you're more insecure, you're more anxious. If you're homeless, we've heard about the rates of homelessness, particularly amongst people with mental health. And it might be that mental health contributes to homelessness, but it also is a result of homelessness. People feel less safe, they're more open to infectious diseases. There's the stress and humiliation of dealing with welfare agencies, loneliness, because when we've done surveys, people living on very low incomes talk about how they can't afford to socialize through having a coffee or lunch with people because that costs money. So poverty cuts you off from other people. People delay seeking care because they can't afford it, or they have other barriers to access. It might be transport. They're often eating cheap food that is unhealthy, high in fat and high in sugar. And of course, that's linked to depression itself. And then there are kind of crimes of desperation, such as shoplifting. Just trying to make yourself make ends meet can lead to you getting into more trouble. But the important thing we have to remember about the inequities, and this is work by Richard Wilkinson and Kate Pickett, and when they looked at countries, in this case it's OECD countries, and plotted them, on the bottom is against how unequal the income is, and on this one is the percentage with mental illness, you'll see that there's this correlation between living in an unequal society and high rates of mental illness. So this is just demonstrating that these kind of abstract concepts, such as income inequality, have very real effects on us. If you live in a society in Japan, Japan has much lower rates of mental illness, but it also has a much more equal income distribution. And you can see that we are one of the worst, on a par with the UK, and just a little below the US, where this is most evident. And if we then think about one of those determinants in everyday life, if we think about education, here's just a whole series of measures of what people learn by their socioeconomic status. If you look at the early years, how many children are developmentally on track in all kind of domains, and 85% of the high socioeconomic group are, but only 67% of the low socioeconomic group. So these patterns of inequity are feeding into children at a very early age. And by the time people are young adults, 86% of the high group are getting a post-school qualification, but only a little over half of the children in the lowest group. So you can see how those inequities are reverberating through the life course. This is about percentage of students who are above the minimum standard in reading and numeracy. And if you look at year 3, you can see again that gradient from the lowest up to the highest. And similarly in year 9, we still got that gradient. So that is ricocheting through our educational system, those inequities. Then if we look at employment and unemployment, what we see there is that if you're in the most advantaged group, you're much less likely to be unemployed. And in fact, this is one of the few measures that has slightly improved in terms of inequity. Whereas in 1986, it was 3 times the difference between the high and low group, whereas that decreased in 2021 to 2.5 times. I think that's probably because we're in an era of quite full employment at the moment, at least in the official records. And this is just American data, but about job losses over the period of the pandemic. And I think it would be pretty much the same in Australia, that again, the lowest income people they had the highest job losses during the pandemic. So in terms of employment and health, obviously good quality jobs are good for your health. We know that. And unemployment, and also I have to say poor quality jobs, so such as informal, casual, gig, are bad for the health, particularly mental health. So, while an employer might see benefits from that kind of insecure employment or gig employment, it's also then giving a burden to the rest of society, because they're much more likely to create the conditions in which people suffer probably physical and mental health illnesses. And then thinking of another everyday living conditions, if we think of housing, this is the top thick line, the top blue line is people in the lowest quintile, and showing how much housing costs are a percentage of their disposable income. And again, the less you earn, the more you're paying as a percentage of your total income on housing. And you can imagine how stressful it is when you're paying nearly 30% of your income on housing. So that, again, is a situation that's not really very good for health. And the housing instability does create mental stress, and mental stress probably also creates housing stability. There's a two-way relationship there. But the mental health diagnosis is much worse in the chronically unstable homeless group. Homelessness is really bad for your mental health, and I think Brian has made that case very clearly, how it would make sense for governments to ensure that people had a roof over their head. I think one of the big reasons we haven't is that we really haven't invested in public housing in the last 3-4 decades. And that's, I think, made a massive and really skewed our housing market in Australia. And it's also worth noting that people living in private rental accommodation report or more at risk of mental health than people who are living in their own house or in social housing. So I imagine, and I don't think that the same is found in countries like Germany, Switzerland and Europe, where people have much more security of tenure when they have a private rental house. Here, people have very little, and that insecurity is not good for anyone's house. And obviously, the other area in which poverty and not having enough money to live on affects people is having access to healthcare. And this is just figures on how people go without access to healthcare, or they make the decision not to go to the GP or their next appointment with a specialist because they simply can't afford it. And what we know in Australia is that gap, the fee gap, is getting larger and larger. It's hard for people to find a bulk billing general practitioner, and it's hard to find a specialist who doesn't lead you with a big hole in your pocket. And there are 3 dimensions of access to healthcare: how available they are. So in many areas, particularly in outer suburbs and rural areas, it's very hard to even find an appointment with a GP, even if you can afford it. And the affordability is becoming less and less affordable to people, particularly to people on low income. And of course, it's also about the acceptability of services. So maybe you feel that the GP doesn't have enough knowledge of the condition you have, or they're culturally inappropriate, or you don't speak English very well. So all those things would affect your access to services. And if we compare Australia internationally, you can see that in terms of being a lower or higher performing country in terms of affordability, we are a lower performing country, and only the US and Switzerland are below us. So that means that I think over the last 2 decades, there's been a creep in the gaps. I'm sure many people experience this when you go and see a healthcare practitioner, and we used to be more affordable than we are now. And there's also been studies of inequities in mental health care in Australia. And this study, which used data from the Hilda survey, which has been surveying people over time about their household income and what work they do. And it notes that there's a significant increase in unmet need in psychiatric care since 2009. And I'm sure that there was before that, but it's increased dramatically since 2009. And women seem to experience greater inequities in access than men do. And surprisingly, this study found that urban residents have greater need than rural residents. So that was an interesting one for me. And they didn't find so much socioeconomic difference in access to healthcare. So I think that raises the question of where do we invest? And it seems to me in Australia, we really have ambulances at the bottom of the cliff. We're not stopping people falling off the cliff. We're investing more resources in those ambulances and in some aspects of healthcare, but we're not asking the question, how do we prevent people experiencing mental distress, or how do we ensure that people do have services when they need them before they get to be living in a crisis? So we have lots of support lines. We hear a lot about those, but to get a health minister to focus on prevention is extraordinarily hard because their whole attention is taken on the acute care system. I think in just about every state in Australia, we hear about hospital ramping, hospital beds, but how often do you hear about the lack of investment in prevention? And I think that's a major issue for Australia to invest in. And I did some research with colleagues around the world on the COVID pandemic and the social determinants of health. And not surprisingly, we found that whether or not you had a secure home, whether you had a secure job, whether you were eligible for income maintenance, whether you were able to access support systems in your country made a massive difference to how well you fared during COVID. And of course, low-income people in gig employment and so on did really badly. And we also have noticed, and I'll say a bit about this later, that during COVID, many countries became less open to civil society action, which of course is one of the ways, in a way, if you like, that's a kind of protective factor for a society when you have strong civil society action. And I think the presence of so many people here with lived experience is sort of testimony to why that's important. So we really do need to look below the surface. When you present at a mental health facility, yes, you see the visible manifestations of mental illness and despair, but it's much harder to see these preventive factors or these factors that would help us create a healthy society are really given very little attention by governments. And this is me with my stepson, Damon. Damon chose to end his life in December the 23rd in 1999. And obviously since then, we've spent a long time thinking about the big question of, Damon, why did you do that? And at the time I was president of the Public Health Association of Australia, and we had a 1-year only essay prize on the sort of underlying factors of suicide. And the responses that we got, the prize was won by Richard Eckersley. Some of you may be familiar with the research that he's done on young people's mental health. But we were looking at questions, why were so many of those young men born in the early 70s, why did so many of them commit suicide? Damon was one of those. What was the nature of the changing gender relations that those young men had to tackle? Why was that threatening to them? What were the employment conditions? Damon had had a really bad experience of leaving a job, going to another one, asked to go to another one, and then the company cut him off just before Christmas, and apparently did that every year. So those sorts of factors. the focus on unrealistic expectations of masculinity. All those factors we know can feed into why people have to make such a heart-wrenching decision. And as a sociologist, of course, I look back to the sociologist who's most famous for talking about suicide, Durkheim. And he made the point, the very powerful point, that yes, suicide is a personal act, but it also, almost paradoxically, reflects what's going on in society. And he looked at the shift away from traditional societies, rural societies, to industrial societies. He was writing at the sort of second half of the 19th century. And he pointed out that the whole issue of integration with communities had become much more fraught under the processes of industrialization. And he also talked about the kind of regulations that are in a society. Do we agree on those? How much are they influencing individuals? And he concluded that suicide really is something that's very reactive to the conditions in society. And I think, unfortunately, what we're doing now is creating a world in which suicide is more likely. And it's very hard, I think, to go from the individual causes of suicide to think about those social structural ones. I just looked at the Black Dog Institute. I'm sure I could have looked at many others. And the sort of factors they look at are stressful life events, trauma, physical illness, drug, alcohol abuse, and so on. And all those are factors. But we also need to ask, what are those structural causes? So in Europe, austerity has been strongly associated with suicide. Financial recession. We've known since the 1930s that unemployment has been a powerful factor. We know the pressure on small farmers, both in Australia, but also in India and other countries. We know that heterosexual norms can be really discriminatory in a society where people have a range of sexualities and they feel unaccepted and pressurized to conform to a norm that isn't theirs. And of course, we have strong colonial heritages, which are very, very evident, I think, through Australian society and through those rates of much higher suicide amongst our First Nations people. So thinking about these determinants, how do they actually get under our brain? Well, a lot of the biological mechanisms, of course, are through long-term chronic stress. There's an increasing literature on that, but you can see how all these factors, if you don't have control at home and work, if you don't live in a society that doesn't discriminate, if you live in poverty, if you don't have good social networks, if you're lonely, there are so many interacting factors that come together in one individual's experience, but they're also reflecting rates at a societal level. So it's not just about individuals, it's much more about society. And let's think about what our society is like at the moment. We've got a series of polycrises. We've got a cost of living crisis. We've got social crisis with isolation, people not feeling solidarity with other people, feeling isolated. We've got a whole industry of advertising that's really aiming to make you feel that you're missing out, you're not doing as well as your neighbor. We've got a political leadership which often seems deaf to what people are saying. And in many countries, we've got a sort of crude populism that is attractive to people, but is also becoming quite dangerous. We have increasing war and conflict. We only have to look to Ukraine to see that, but in many other areas of the world, we have this sort of tensions that between China, the US, that we live with very much in this region. And then we have an ecological crisis, a climate crisis. And at the middle of all this, I think, is a very unfair economic system, which is driving this kind of corporatization of the world, exploitation of natural resources, and overconsumption for some people, unhealthy overconsumption, and in other parts of the world, underconsumption. So this is just a shareholder meeting saying, I too hate being a greedy bastard, but we have a responsibility to our shareholders. That's a cartoon, but it's also the truth. If you head a corporation, your first responsibility under the law is to make a profit for your shareholders, not to protect the health of populations. And I think Brian made the point that that is the role of governments, you know, to protect our health. And I'm interested that in the public health literature, more and more people are going back to Karl Marx and looking at what he said. And these points are from the editor of The Lancet, not from some radical, Richard Horton, who wrote about this 6 years ago, where he said, well, Marx could be helpful to us. He critiques society, critiques privatization, colonialism, and so on. He offers a set of values about freedom for individuals, equitable society, ending exploitation, and it's also a call for people to do something about the situation, to rise up. And in the public health literature, there's more and more people saying, maybe we need a strong political economy understanding of what's happening in our world. I'm just going to look at some of those factors, starting with the climate crisis and how that might affect our mental health. I think this is Antonio Guterres, who's the Secretary General of the United Nations. And I think he's doing an amazing job of warning the world of how much we are at risk. And here he says we're on a highway to climate hell with our foot still on the accelerator, and yet no one's making any difference. So he's a very, very powerful advocate. If you look at this, the red line, all the black lines down the bottom were what between 2003 and 2022 was the wildfire carbon emissions in Canada. This year is the red line. I mean, that is astounding when you look at that difference. And when you think that's happening in Europe, it's happening, the tundra is burning in Siberia. I mean, as Antonio Guterres says, we're really in a terrible period. Also, he has also warned us in July this year that we've seen the hottest 3-week period ever, the 3 hottest days ever on record, and the highest ever ocean temperatures for that time of the year. So a real climate emergency. And I think particularly on young people, that has a real mental health effect. I don't think we can talk about the mental health of young people without thinking about the climate crisis. We all know Greta Thunberg, and she says, you know, I don't want you to be hopeful. I want you to panic and act as if the house is on fire. But imagine that's what a young person's thinking. When I was her age, I had this automatic assumption that things would get better. I didn't think that things were going to get worse. I assumed that for everybody, the world was getting better. This generation of young people is growing up assuming that things are getting worse, and watching things get worse. And we only have to look at the school strikes for climate. This is taken in one of the Adelaide school strikes, where school children are saying, we are scared of the future, we want a better future. And even in the climate crisis, we see these inequities. And in Australia, to keep on going as we are with the way that we're using our ecological footprint, we'd need nearly 7 planets worth. Qatar, which is the highest, would need over 11 planets. And even in Africa, 10 countries are well above living on 1 planet. So that's a very powerful message to us. And I think particularly when young people see that, they realize that we've created a society that is not sustainable. So that's the first kind of structural condition I want to look at. The next one is just to touch briefly on racism. There's been much more attention to racism in the public health literature, and it's now accepted that racism is a major structural factor driving ill health, particularly for First Nations people or people who are of an ethnicity which isn't the majority in the country. We did a study over a decade ago in Adelaide where we talked to 149 Aboriginal people. And I was actually shocked by the degree of racism that was reported in Adelaide. My own naivety, I realise. But just the first quote, when someone says, I'm not coping with people with racism, I think in a way it has affected my health, the racism that I grew up with and that, you know. And then Shane said, purely because with racism you feel depressed, which could then, you know, go into eating the wrong thing, drinking, smoking, whatever. So, yeah. So, you know, we found that most Aboriginal people we spoke to had experienced racism, and that many of them reported leaving their house every day. They knew that they might be subjected to a racist assault, whether it's in a shop, whether people not wanting to sit next to you on a bus or whatever. So that's something that's very alive in our own society. Now, the other determinants that I think are grossly threatening our mental health at the moment are what are called commercial determinants of health. And I just recently worked with colleagues, and we published an article in the Lancet where we defined commercial determinants as the systems, practices, and pathways through which commercial actors drive health and equity. And I also quote from the Australian Medical Association. They have a position paper on the social determinants of health, and there they recognise that the commercial conditions in which people live are affecting their health. In the Lancet article, we put forward a model of the commercial determinants of health. And what we suggest is that a whole lot of practices, particularly of big corporations, are actually a threat to the health of just everybody on the planet. And this model sort of goes into detail of how that's happening. But the sort of practices that affect health are, first of all, tax evasion, I think, is a massive one. And we all know, this corporation didn't pay this much tax. There's been the scandal with PwC working for our tax office and advising corporations. But what that means is there is less money for health and education and housing, all those things that support our health. So it's not just unfair they're not paying tax, but it's unfair that we have governments saying we don't have money to do that. If we had that tax, we'd have money to do so much more. Advertising encourages the consumption of unhealthy products and changes cultures, whether that's gambling advertising during our sport, fast food advertising, alcohol advertising. There's a strong influence of science through the universities' funding. There's a strong literature on that now. A history of many corporations denying health impacts. We've seen that powerfully with smoking and lung cancer. We're now seeing it with alcohol and breast cancer and other cancers. Corporations systematically try to shift the burden to individuals, saying, oh, it's their fault, there's something wrong with them, they should do more exercise, they should look after themselves better. They lobby governments for corporate-friendly policies. And I think it's an irony that we're arguing for a voice to Parliament, and people are saying, oh, some of the people on the no side are saying people shouldn't have special access. Well, at the moment, the strongest voice to Parliament is the corporate sector, and it's massive. And if you only have to look at our policies on fossil fuels, and you'll see how massive that is. Then numerous conflicts of interest as people move from government to corporations. Very often corporate social responsibility is window dressing. It's now called health washing or greenwashing. Corporations externalize their costs, whether that's environmental waste or pollution, and they have a very direct influence on policy through the sorts of consultancies we've been hearing about in recent years. And there's an increasing literature on this, the commercial determinants of health. Nicholas Freudenberg in the US described it as legal but lethal. Or lethal but legal, rather, yes. And he's written a book about how these corporate practices really undermine health. We've done a whole lot of research on the health impacts of transnational corporations, trying to look at what are the benefits they offer and what are the shortcomings. We developed a kind of framework where we looked at the sort of regulatory impacts. Are they strong enough or not? How do they directly impact on health and equity? And how do they affect living conditions, whether that's the environment through extractive industries or the creation of a market for unhealthy foods. We really thought about what in their production is unhealthy. That might be bad working conditions, the way extractive industries spoil country, the way they produce high fat and sugar food, and how they manufacture demand for unnecessary products. If you go into our supermarkets, the range of choice we have is astounding. Is that where we really should be investing the resources of the planet? And then in terms of consumption, again, there's the pushing of addictive products, the sort of status competition that's heightened through advertising. So people are deliberately manipulated to feel that they're losing out. materialistic values are really strongly engendered, and they really have been shown to have an impact on the symptoms of anxiety and depression. And very often the forced privatization of services is focused on profit, if you think back to the corporate board, rather than public good. So the question is either how do we provide good public services and take those back into public ownership, or regulate the private companies so that they do take equity issues and so on into account. There's also more and more books. How many people have read Gabor Mate's work? Yeah, quite a few people here. I think he's really good on linking private problems with these public issues. He calls it the myth of the normal. He talks about how so many of these unhealthy things have become normal through different processes. And Anne Case and Angus Deaton have talked about the deaths of despair and the future of capitalism in the US, particularly focusing on the fentanyl epidemic, but also just looking at the reason why now in the US, life expectancy for some groups is going backwards. The same in the UK, the lowest group has lower life expectancy, and I fear that we will see that in Australia before too long. There's been a real resurgence again in the public health literature of the concept of social murder that Engels introduced with his book of the English working class, when he looked at the impact of the Industrial Revolution on people's health and showed how it had affected their health so badly. And this notion of structural violence, some of you may be familiar with the work of Paul Farmer, who's done amazing work with low-income countries in Africa and in the Caribbean. And he says that structural violence is often embedded in long-standing, ubiquitous social structures normalized by stable institutions and regular experience. So it's that same idea that we've managed to create a society where we accept all these things that are making us sick. What about robo-debt? We've all heard about that and the devastating impact that it had on people. I looked at their submission to the inquiry. And they said tens of thousands of those impacted by the robo-debt scheme would have been receiving support because they were struggling with severe or lifelong mental illness and were instead persecuted with false debts. And I think we heard the sort of devastating submissions and people giving their testimonies to that inquiry and what a devastating effect it had on people. And I was glad to see that the College of Psychiatry also made a submission pointing that out. And the Banking Commission, you think, well, what's a banking condition got to do with mental health? Well, in fact, this is a submission from Mental Health Australia, where they pointed out how that banking practices, insurance companies, has had a very detrimental impact on people's health. I also think increasingly the stress of dealing with a technological and corporatized world. How many of you have stood in line talking to an energy company, talking to an IT provider? And I love this cartoon where he says, okay, one more time, go home, log on to our website from your computer, create an account and purchase your ticket with your credit or debit card, download the ticket to a smartphone, then come back at the allocated time. Just what part of easier and more convenient don't you get? How many of you have felt like that? How stressful is it? And especially if you're poor and you don't have the resources to even begin to think about challenging a bureaucracy. And yet I would find I have that kind of experience 3 times a week. How many people feel that they also have those kind of experiences? Yeah. And it is just so frustrating. So the question I ask, are we talking about a sick society or sick individuals? And is it mentally healthy to be well adjusted to a sick society? So maybe it's those, you know, I've certainly suffered from quite bad depression myself. And sometimes I think it's a kind of reaction to a sick society. So I'm going to end on a more positive note, which is how do we create a mentally healthy society? I think we have to move away from a primary focus on biomedical approach to a sort of social health understanding. And we need to treat our sick society as well as sick individuals. It's just as important. Those are the things I think that would make a healthy society: lifelong learning, employment, healthcare, housing, good ecological health, economic factors, and transparent and inclusive governance. So what creates a mentally healthy society? Well, the WHO says it's a state of well-being in which each individual can realize their potential. Vic Health say it's a dynamic state in which people are able to develop their potential, work productively and creatively, build positive and respectful relationships with others, and meaningfully contribute to the community. They're pretty good. We certainly need lifelong learning. I think instituting free education throughout life would be great. Many people in my generation had that. I would never have gone to university as a working class kid if my fees had been free. My parents would have thought I should have been working, and that's what would have happened. We know we have to invest in early childhood development. That is essential. And we need lifelong learning skills about how we relate to people, how we reskill ourselves. And that can be through schools, universities, community centres, workplaces, and so on. And if we had all that tax, remember, we'd be able to afford this. Unemployment, we need to create meaningful, secure work, a livable income for those on welfare. At the moment, it's impossible to live healthily on welfare. You just can't do it. So why would we do that? To take our most vulnerable people and make sure they can't be healthy. We need gender equity, and we need to value unpaid work, all the people who care for people who require that care. Social welfare systems are really important. They keep people healthy. When a study was done comparing Sweden and Spain in response to both the 92 crisis and also the financial crisis, it was found that in Sweden, there wasn't epidemic of mental health issues because there was support for people. In Spain, there wasn't, and there was a massive mental health crisis in the country. So that action needs to be universal, not totally targeted. If we have universal support, it's much more effective in approaching everyone in the government. I think the OECD has published a report, a new benchmark for mental health systems, and those are its main messages, which I think you guys have all taken on, that you need to involve patients, you need to destigmatize, you need rapid and helpful support, you have to support post-recovery, and you have to integrate with the rest of the health system. And I think probably the best places that do that are community health centres and, I missed that one, and Aboriginal community-controlled health services. Certainly in the study where we talked to and were advised by people working in the mental health system, it was very clear that priority populations should be tied to public investment and tailored strategies to meet the needs of those priority populations. But there also needed to be the whole of population strategies to promote mental health and psychological well-being and to address social determinants. So that was a very strong message from the field. People understand that, and I think most of you here do as well. I do think Aboriginal community-controlled health services are an amazing model. There's increasing evidence of the effectiveness of that, and just shows when you put health in people's hands, it works. When you impose things on people, it doesn't work. And I think we need to increase block funding to those services so they're not applying for multiple pots of money with different accountabilities, which I'm sure people who work in NGOs know about. And of course, there's still Aboriginal people are still dealing with the challenges of colonialism. In your state, I've worked closely with Waminda, which is a Aboriginal women's community health centre on the South Coast, and they have this amazing model of care where they really do try and look at the whole person and respond to that, not just to people who are sick. Housing, again, we need safe and secure housing for all. It is crazy that we have a housing crisis in Australia, the second richest country in the world, because of policies like negative gearing, because of policies that encourage people to see housing as an investment rather than somewhere to live. And we really need to create not just good houses, but good communities where there are places people can meet, where there is interaction, which can reduce loneliness for people, and really planning our cities for people, not for profit. Ecological health, there is so much evidence now that exercise in the open air, that being in nature is good for our mental health. And I think we can all experience that. If we walk on a beach, if we go to a forest, it's fantastic. You feel better. And then economically, how can we, instead of just measuring GDP, can we start measuring how effective we are at keeping people well, at people feeling that sense of control, that sense of purpose over their lives. And I've just put this slide in to show that health depends on distribution, not wealth. If you look at the top, Costa Rican people live longer than people in the US, and yet their infant mortality rate is just a tiny bit higher, yet they spend a fraction per head of population, and these are kind of adjusted rates, and their GDP is 13,000 per head. The US is 76,000. The US spends nearly 12,000 per head. Costa Rica spends under $2,000 per head, and yet they're getting much better results. And one thing that explains it is the Happy Planet Index, where they're #1 in the world. They invest in primary healthcare, they invest in prevention, they invest in education. So you don't have to be a wealthy country to be a healthy country. It all depends on how you decide to distribute your resources. And there's a lot of people are focusing on a well-being economy. How does it help with mental health? And Vic Health are saying, yes, it will support positive mental health outcomes, because it's defining markers of progress as the things that serve the well-being of people. And this is just the Canadian Index of Wellbeing over the last years. You can see that GDP was soaring, but well-being wasn't soaring at the same rate. So there's some mismatch there between what's going on. So I think we need a fiscal policy for health equity. Again, progressive taxation, universal basic income. You know, we need a campaign. SACOS, our peak body for community services in South Australia, ran a campaign saying without taxes, essential services disappear. I think that was very good. And thinking about alternative economic models that aren't just based on growth and profit, but emphasize how much is this society creating well-being for people. I've always looked at cooperatives because I think they're very interesting, that they're very local generally. Workers can participate in the management. They can be responsive to their communities. And people have also looked at the mental health and found that cooperatives create much better mental health in their employees. So someone here says this is one of the most challenging times to be a young person in the UK, but there's hope. Ownership and control aids mental health and well-being significant. The cooperative movement is a beacon of hope for those who want more control of the future. And we then finally need governance that is just. And really that's about how we can create a democratic society. I'm being given the thing to close down. We have written about cultural safety in Australian public policy. We've used frameworks from health. And what we've discovered is that a lot of Australian public policy isn't safe. I think the Uluru statement from the heart was asking us all to look into our hearts, that whispering in our hearts, and ask, well, what should we do when the 14th of October comes around? And Aboriginal self-determination has been shown to be good for health. So the voice is another step along that path. I recently wrote an article with Pat Anderson and Megan Davis about why constitutional recognition would be likely to improve the health of Aboriginal people. And I think the people have spoken about hope today. And I think Barack Obama put this very well when he said the best way not to feel hopeless is to get up and do something. And he said, then you can fill the world with hope and you will fill yourself with hope. So I think I'll finish on that note. Thank you very much for listening.